millicents. Okay.
Dr. Millicent, just confirm you can hear so that we know, and as well as Dr. Nafula.
I can hear you.
Great. Millicent? Okay, Dr. Coril, I can see you. You're able to hear us?
Can you hear me now?
Yes, now
David?
we can hear. We can hear you now.
Okay.
Okay, can see about 32 participants, and it's 19:05. So I hand over to you to proceed, probably in the next 2 to 3 minutes.
Hello, David. We can look in. Okay. Okay. Good evening. I hope you can all hear me.
Yes.
So you can. So thank you very much for joining this very important session this evening. My name is Dr. Millicent Korir. I am a psychiatrist working at Moi Teaching and Referral Hospital, but more importantly, I'm a palliative care champion. And today, we want to go through a very important topic, quite a gray area when it comes to palliative care in children, and that is palliative ethical considerations when dealing with palliative care in children. And so today we have Dr. Esther Nafula, who is a palliative care doctor working at Kehpca, who will be taking us through this session today. We'll have about 40 minutes of presentation, and then after that we will have a question and answer session. We like to request people to send their questions through the chat as we go along with the presentation, so that these questions can then be addressed at the end of the chat. So without any further ado, let me welcome Dr. Esther Nafula to continue with the presentation.
Thank you. Let me share my screen. Can you see my screen?
Yes, I can see your screen, but the slides are not yet up. There
And
we have
now?
them.
Okay.
Yes, we can see them. Maybe put them in a slideshow mode.
I already did that on my side. How is it showing on your side? Is it on slideshow?
No, not yet. It's not on slideshow yet.
So this evening we are going to look at ethical issues in pediatric palliative care. And yeah, I'll take just about 40 to 45 minutes for the presentation, then we can have time for discussion. Is the presentation on slideshow now?
Not yet, Daktari.
On my side, it's on slideshow, so I don't know what more I can do, but you're able to see the slides.
We can see the slides, yes.
Okay. All right. So I'll start with a case. Elsa is a 3.5-year-old girl who lives about 1.5-hour drive from a tertiary center with her parents and a 6-month-old sister. She has just been diagnosed with a neuroblastoma stage 4 involving multiple bones in her bone marrow. What I would like us to think about is what is likely to be unique about handling a child who needs palliative care, the major challenges in decision making during the care of children and adolescents who have a life-limiting or a life-threatening illness. So from that case, we can pick out the patient is 3.5 years, so her level of understanding of illness is limited. Number 2, she's not able to make any decisions. The parents have to make decisions on her behalf. And these are some of the things that will come through the presentation. So the objective is to improve your knowledge on ethical principles in palliative care, to discuss some major challenges in decision-making in pediatric palliative care, and
So-
to
sorry,
look at
sorry.
handling ethical issues.
Esther, sorry to interrupt. The slides are not moving from the. Yeah.
Okay, let me try again.
Okay.
Entire screen. How about now?
Now, okay.
Yes, good now.
Okay. So there are 4 ethical principles that guide healthcare, and this is beneficence, non-maleficence, justice, and autonomy. So beneficence is about considering the best interest of the child. In this case, our patient is pediatric, so I'll be referring to the patients as children. So for children, we have substitute decision makers who are usually the parents. They're the ones who make decisions in the best interest of the child. Now, sometimes there's conflict between the medical team and the parents, and it's therefore very hard to establish what the best interest of the child really is, because parents are taught to act in the best interest of their children. They are taught to make decisions that are good for their children. But we have a lot of cases where parents decline treatment that might be considered life-saving treatment. Some parents have declined chemotherapy, some have declined blood transfusions, some have declined amputations. And the question becomes, what really is in the best interest of the child? The decision that the parent makes or the decision that the clinical team makes? When it comes to autonomy, children do not have the capacity to make decisions, especially young children. And even when they're adolescents, the law does not allow them to decide. So as much as a child above 12 years can have opinions about their treatment, the law does not allow them to make decisions. Then also, as children develop over time, their cognitive and emotional awareness changes. So they tend to understand illness better. An older child is likely to understand the implications of having a serious illness as compared to a younger child. So older children sometimes want to be involved in decision making, and later on we'll see whether to do that and how to do that. Now, again, when it comes to informed choice, it's the parents who make decisions for children, and they make these decisions based on the information that we've given them. So the amount of information we disclose, what we share with them, is what determines the kind of choices that they make. Sometimes in the cases where parents have declined treatment, it's usually a matter of a misunderstanding or misinformation. They have not been furnished with sufficient information about a disease process, treatment options. So sometimes they'll make decisions that we consider to be not to be in the best interest of the children, but it could just be that we have not given them enough information to make a decision. We have not explored their expectations, perceptions, misperceptions, beliefs, and values. So it is very common to hear among parents of children receiving palliative care that their child has been bewitched. Some of them think it is a spiritual problem that they can pray it away. Do we explore these things when we are communicating with parents, or we simply just tell them, okay, your daughter is 3.5, we found that she has a neuroblastoma, it is metastatic, and this is the treatment? How do we actually ensure that we effectively communicate with the parents so that they're able to make an informed choice? You do realize that ethics is about a lot of brainstorming and a lot of questions. So sometimes there's no straight answer, but we deliberate and come to a decision that will serve the patient best. And in palliative care, the aim is to improve the quality of life of the child and their family. So there is a lot of uncertainty around prognosis of children. It is not very easy to predict how illness is going to be for a child. It's not the same in adult population, and children have various phases of deterioration, even in end of life. Sometimes we have children who get very sick. We think they are going to die, and then they recover, they get very sick again. So it is very uncertain. Um, and then the societal perspective is that we need to do everything possible for a child. So this is shared by the parents, it is shared by the healthcare providers. Our treatments are aimed at curing the child at all costs. Even at times when the child's health is not getting better, there's still a lot of focus on trying to get an intervention that will work, which sometimes is not what palliative care stands for, as we look at improving the quality of life of the child. But the society does not believe in giving up where children are concerned. It's considered giving up when we withhold or withdraw care. So how do we actually create a balance of the two, quality of life versus pursuing cure at all costs? So there's a lot of debates also on when to integrate palliative care. Should palliative care be introduced early at the time of diagnosis? Sometimes we are told that bringing in the palliative care team is going to discourage the parents, or it is not time for palliative care, it's not the right time. So when is the right time to start talking about palliative care? And for many clinicians and healthcare providers, the experience of caring for a dying child is extremely stressful. There's a lot of grief that is associated with the children being terminally ill or children having a life-threatening or life-limiting illness. So where cure is not possible, you find that the healthcare teams are greatly discouraged, and this sometimes impacts on decision making because our emotions get in the way. And it's very common to hear healthcare providers comparing the child who is sick with their own children and saying, I see this child and I picture my child. And it gets very, very emotional and very stressful. Now, sometimes you find that you are working in the children's space. As much as it's emotionally involving, you still have to do it because we have very limited expertise where children are concerned, both from the pediatric specializations and palliative care. So again, as we are taking care of children, it's good to remember that we need to also take care of our own emotions so that we are able to help the parents to make good decisions for their children. Let's look at the parties involved in care of the children. So we start with the children themselves. Some children are too young to participate in decision making, and they could also be too sick. And some are old enough to understand that they are sick and old enough for us to have conversations with them. So there's a large group of children who can express their wishes and should be involved in decisions. And this starts with us talking to the parents. Remember, the law in Kenya defines a child as anyone less than the age of 18. Now, children cannot make decisions by themselves, and we also cannot communicate with children without the consent of their parents. So first, we need to obtain consent, and where possible, let it be written consent from the parents that they've allowed you to discuss issues of illness and treatment with their child. And then be very specific about the issues you want to discuss with the child. So if it's issues around illness, issues around the diagnosis, treatment, side effects, prognosis, get explicit consent from the parents. And if the parents are not comfortable for you to share some information with the children, respect their wishes. So some of the challenges that we face include the variable understanding of death. So at some developmental stage, like children between 0 and 3 have no concept of illness, they have no concept of death. They work with instinct. They just sense that something is wrong. The ones from 4 to 6 years have a limited understanding about illness. They do not know the implications of serious illness, but they know I'm sick, they know I'm in hospital, I'm getting this treatment, I've been here for a long time, this hurts, that much they understand. Then from 7 years to 12, preteens, They are very inquisitive. They have a better understanding about serious illness and about death being a permanent state. And teenagers are starting to get their own identity. So they completely understand what it means to be sick, what it means to die, and they do have some of their own wishes. So in our cultures, the families wish to protect children from details of illness, from decision making, and many children are barely told what the problem is. They'll be carried to hospital, they are brought to us, we need to treat them, but the child has no clue, no idea what is happening with them. Children also wish to protect their parents from difficult thoughts and feelings. So children who witness their parents crying after receiving bad news, or they witness their parents becoming very stressed when they are sick. Sometimes the children blame themselves for being sick, or when they come to hospital, they'll withhold information. The body language would tell you a child is very distressed or in pain, but the child is telling you no. And sometimes when you inquire, you find that the child is trying to protect their parents from the difficult situation. So they'll tell you that if I say I have pain, my mother is going to get upset, or I really want to go home because I can see being in hospital is stressing my parents. So everyone is trying to protect the other one. Adolescents have unique challenges in decision making because they are very concerned about their identity and their body image. They are concerned about what their peers will say about them, and they want autonomy from the family. They're trying to find themselves, so they want to make decisions for themselves. They want some independence. So as much as they might be capable of deciding what should happen to them, the law still prohibits children from making decisions about their health care. So sometimes they might not agree with the treatment that we are proposing. They might even not agree with their parents. And remember also during teenagehood, some teenagers are rebellious, they're going through a phase. So it is very important to empower the teenager, but to also empower the parents to be able to navigate the difficult conversation. And we have a lot of materials and aids that help us to communicate with children and even adolescents. There are some tools that are used to help us to understand what the wishes of an adolescent are, to understand their anxieties and fears about illness, about death, and to be able to create an environment where they can actually communicate effectively with the parents. So as much as the decision will still lie with the parent, the adolescent child will feel they were involved in making the decision. So they are more likely to cooperate with the treatment, the follow-up plans, because they feel they were involved. Adolescents sometimes with the HIV, with sickle cell, sometimes they are even in boarding school and they go to school with their drugs and they throw the drugs away because they feel nobody is giving me attention. So they throw the drugs away and they end up in more crisis and more health problems than at the time they were in hospital. So it's good to consider these things. How do we make the child feel involved? As much as the decision will still come from their parent, how do we communicate with them? How do we make them own the process, own the disease, and own their decisions? The next party involved the substitute decision makers. So I'm calling them substitute or proxy decision makers because not in all situations do we have parents. So it is very ideal when we have the parents to the children to make decisions, but sometimes the parents are unable, unwilling, or incapable to act as decision makers. And I'll explain some of the scenarios that we face. The first common scenario is broken families or single parent families. So we have couples that have separated, everyone went their own way. Now a child is sick, seriously ill, with a life-limiting, life-threatening condition, and the parent who is with the child is unable to decide what should happen to the child. And we call in the other parent because legally a parent has a right over their child, even if the child is not in their custody. So the other parent comes and sometimes they make a very conflicting decision from the parent who is in hospital with us. And sometimes because of the unresolved conflicts, they bring this conflict to the hospital. So such situations often result, of course, in us not even being able to manage the child well. And we've had lots of children who sometimes tell you they do not want to talk about their family because the family is also a source of stress. Now, in situations where we have one parent who is maybe unable to make a decision, we have to call in the other parent. But as we do so, it's important to understand the social support system for the parent who's actually taking care of the child. Because sometimes we do more harm bringing in the deadbeat parent to the care of the child, and sometimes these children were not even aware. So some parents have left when the children are very young. They're being raised by step parents. Now a child is sick and another man or woman is showing up as their mother or their father, yet we are supposed to be offering social and psychological support to the child. So legally here in Kenya, the decision makers are the parents. And sometimes, again, these parents are not there. They've gone off to work abroad and left the child. And we have the grandparents. And sometimes the grandparents or the uncles, aunties are telling you, I cannot make a decision. We had a child who had a metastatic nephroblastoma. And when we did all the investigations and now needed to start him on treatment, the caregiver who was there, all the whole time he was saying he's the dad to the child when he came. But now when it came time to make a decision about treatment, because we are now giving palliative treatment, it is not curative, and we are discussing with him the prognosis and cure is not possible. That's the point at which he told us, take a pause. I'm the uncle to the child. Let me see if the child's mother can come. And he has been with the child, taking care of the child in hospital for a period of about 6 months. So these scenarios are very common. And again, there is no correct way to handle those situations because, again, sometimes the parents have not given this uncle, this grandparent, the rights to make decision over their child. And that's why this uncle was saying, let me call the mother to the child because I do not want to be blamed in case anything goes wrong. They'll say I didn't make the correct decision. So that also sometimes delays care because as you're waiting for the mother of the child to travel and come or even to be found, the child is not receiving any care while in our custody. In situations where we are not able to get a decision, the hospitals now have hospital ethics committees that are able to sit, deliberate, and then make a decision in the best interest of the child about how the care should proceed. And in extreme cases, we have had to seek legal help from our courts so that we have a court order to allow us to give treatment, especially if the treatment involves surgery, things that need written consent and there's no one to offer the consent, or the decision makers are taking too long to make a decision and we feel the decision they are making is not in the best interest of the child or is putting the child's life at risk. So we have the legal pathway, but again, this being Kenya, that takes a long time. It takes a long time to obtain a court order. So in situations of emergencies, it is very, very challenging to the healthcare providers. The healthcare teams that take care of children have a wide variety of skills and professions involved. And we often have a team, and most of the time we do not have a structured team that is dedicated to taking care of children needing palliative care. So we have ad hoc teams. So that means in the palliative care team, you might find you have a doctor and you have a nurse. So where you need a social worker, chaplain, legal, we consult from the relevant departments, a psychologist, because we might not have the luxury of having in-house trained personnel dedicated to children. But there is need for collaborative interdisciplinary work so that we are actually able to offer the best care to our children. And sometimes there is a lot of differing opinions. And one of the challenges we face, especially in our setup in Kenya, we use a multidisciplinary approach to take care of children. So what that means is a child who presents like Elsa has a neuroblastoma. So the pediatric oncologist will see the child and say this child needs chemotherapy, this child needs surgery, and then the surgeon will come and they're documenting in the file, this child needs surgery at this time, and after surgery we are going to do 1, 2, 3. So the communication is by the file. So sometimes you find that the opinions are very different. The communication to the parents is so different that the parent gets confused, because one person is talking about palliative care, another person is talking about theater, another one is talking about chemotherapy. So the parent gets confused because we are not speaking in the same language. And it's important for us to look into moving from multidisciplinary approach of care to interdisciplinary, where we are able to have what we call the MDTs. We are able to have a meeting, discuss about the patient, and agree that our goals of care is curative, it's palliative, this is the way forward, and this is the team that is going to communicate with the parents. Because in our situations, parents get a lot of information. So they are getting information from different clinicians, they're getting information from relatives, from the internet. So they get a little more confused, that even making a decision in the best interest of the child becomes very, very difficult. Then again, there's attitudes. I mentioned earlier that taking care of children with life-limiting illnesses can be very stressful. It can be very emotionally draining. And again, our own cultures, values get in the way when we are taking care of children. It is very hard to put boundaries, unlike in adults, because we empathize with the children, we feel sad when we see children suffering, and we really want to do the best to mitigate that suffering. So the decisions that need to be made first is about goals of care. So I'll go through some of the decisions and some of the ethical issues that arise. So I mentioned that prognostication in children is very hard. Even children in palliative care, it's very hard to determine or predict their prognosis. We've seen some responding very well to treatment and even staying with their metastatic cancer or even a congenital anomaly for longer than expected. So sometimes our goals of care are multiple at the same time. You might be pursuing quality of life, but you're also trying to pursue cure. We are looking at things about remission, how to prolong the child's life, then how to maximize a normal experience for the child. How can we ensure that this child, even if they're going to spend time in hospital, our average length of stay in Kehpca, for example, for oncology is about 6 months in hospital, continuous, up to a year. How do we ensure that the child is able to play, is not lagging behind in their schoolwork? The child is just able to be a child. As much as they're in hospital, they're able to enjoy time with their peers, they're able to play, they're still able to get their treatment, while at the same time maximizing comfort and family access. How do we ensure that children have time with their siblings? And then care around end of life. How do we ensure that now when we are getting there to end of life, that we are able to determine a preferred location? And this is mostly for the child, because again, I'll keep saying this because this is what gives us a challenge where children are concerned. The parents are the decision makers. So some children would actually want to die at home, but the parents will prefer them to be in hospital. A lot of children are dying in hospital because in hospital, there is all the resources, there's the availability of doctors, nurses, personnel to help with emergency situations. And then the parents feel that if a child dies in hospital, it means they took better care of them, which again is a societal expectation. A child might want to die at home because that is where the environment where they feel comfortable, that is where their siblings are, that is where the family is. So they feel when they're in their own space, they are more in control. So this is not just for adults, even children, sometimes we are able to establish these issues. As I mentioned, we have tools that help us to communicate with children to understand the needs of the child so that we are able to support them. Now, where a child is too sick and the family is not ready to take the child home, even if the child prefers to go home, can we bring home to the hospital? Can we encourage the parents to bring the toys, books, things at home that give the child comfort? Can we encourage them to bring their siblings to visit the sick child so that they can spend time together? Because these are some of the things that will ensure that we are actually maximizing comfort for the child. Tough decisions come around potentially life-sustaining treatment. So life-sustaining treatment is another term for ICU or life-prolonging treatments, aggressive interventions. So for children, it is very hard to put a pause button and say the prognosis is poor. Now we are shifting to palliative care. We are focusing on pain management, symptom control, and keeping the patient comfortable. So these life-sustaining treatments include mechanical ventilation for breathing, use of vasopressors where there's cardiac impairment. It may include dialysis, antibiotics, organ transplant, chemotherapy, artificial hydration and nutrition, and others. We've seen instances where children have relapsed leukemia and the parents still want us to keep giving chemotherapy even when we feel that chemotherapy is futile. So sometimes from the medical side or from the healthcare side, we feel that these interventions are not helping the child. But the parents tell us, do the best that you can, just do anything to save the child's life. So these decisions are very, very difficult because palliative care neither seeks to hasten death or prolong the life of the patient unnecessarily. But then parents have the hope that where we can try these things, maybe the child can improve. So it's a very tough call. Again, the law is clear that the parents are the decision makers. So even where we feel that the interventions are futile, our role is to try and give them a realistic prognosis. Then we try to give them the interventions that exist. Then we support them in the decision that they make. So even when a parent chooses to take their child into ICU and you can see that this child is in end of life, your role as a healthcare provider is to support them. Don't start commenting that if it was my child, I would not put them through this, because that is not your child. So the parent is the one walking that journey. And sometimes them doing everything that can be done helps them in the bereavement or grief phase. So as much as some interventions may be medically futile, where children are concerned, we leave the decisions to the parents. We only intervene where the parents are now making decisions that we consider to be threatening the life of the child. Like a parent who will decline to have amputation for a child with gangrene, a parent who will decline a blood transfusion and their child is getting into heart failure because of anemia. In such situations is where we can intervene as healthcare providers. There's the issue of artificial nutrition and hydration. Honestly, I was not going to include this in the slides, but this question came up yesterday. We were having a pediatric oncology workshop, and there was a concern about feeding children at the end of life. So again, artificial nutrition and hydration, they are invasive interventions. They may cause additional suffering by adding discomfort. For example, some children might have nausea, vomiting at the end of life, and respiratory secretions generally get worse when we continue feeding the child in the final stages of life. This again is a decision the parents need to make. All you can do is give them information. At the end of life, um, someone does not need food because their metabolism is very slow, and sometimes even the digestive system has shut down. So whatever we feed just comes back or regurgitates and gives more complications, but let the family decide. Then in Kenya, again, our laws do not allow us to stop hydrating patients. So food we can withhold, but water, it's considered illegal. It's actually considered euthanasia if we withhold hydration because the patient is likely going to die of kidney failure. So yes, the patient is in end of life. So that's the thing we are not able to agree on. The patient is in end of life and is dying, but we are still continuing to hydrate them, even though their kidneys are shutting down. But legally, we have to do it. So food we can discuss, but rehydration, we have to do it until the final stages of life. Then culturally also, we believe that eating means we are fine. So it is very common for us to find parents trying to feed the child who even has reduced level of consciousness, and we have to be culturally sensitive. Don't tell them that it's you don't need to feed your child. Discuss with them the implications of feeding and the risks and the processes that the child is going through. But again, we respect their wish. Some have opted for parenteral nutrition. It might not benefit the child who is dying, but it's a comfort for for the parents to know that they did everything possible. And some have anxieties that the child will die of hunger. So the disease process might not be so, they might not be so keen on the disease at that time, but they feel that if I deny my child food, it means the child will die faster. So it's important to understand the meaning that the parents are giving to nutrition, their culture, and basically what is important to them. Because when we are getting to end of life, we are supporting the parents more than we are supporting the children. Relieving of symptoms is a primary care of palliative care, and it's our primary goal. So throughout the illness, regardless of the prognosis, we have to remember that we need to relieve symptoms, and where decisions need to be made about therapies to relieve symptoms, this need to be made quickly. So again, it's important to communicate with the parents first and then the child to understand the medications that they need, how long is it going to be, how long are they going to take it, how are they going to take it, what are some of the side effects they anticipate, and the goals of the children, it's important to know. For children, play is very important. Being active is very important. Some of them love to read, some of them love to draw, they want to watch cartoons. Can we be able to help parents to communicate with the children about these wishes so that they're actually able to meet the wishes? And sometimes, due to family dynamics and financial implications of illness, parents have had to leave children in hospital to go and work because they have bills to pay, they have other children to take care of. It's important for us to empower them to communicate these things, because sometimes older children are left in hospital with us and our care, and the child interprets that I'm too sick or I'm a burden to my parents, that's why they're leaving me here. So it's important that as parents are making decisions, who is going to take care of the child in hospital, who am I delegating the power of attorney to make decisions on my behalf when I'm away. It's important for the child to also be part of that communication, for the child to understand this is the process, this is my illness, this is what I'm going through, so that even the child can express their wishes freely, and that way we can support the child and the parents better. Because sometimes we don't consider these other things, the finances, the social support, the other children who have been left at home, the implications of being in hospital, hospitalized for 6 months. We've even had some men who come and complain and say, now I've had to go maybe look for another wife, or women are telling us now, give me a break, I go home with my child because I actually need to go home, take care of my home, take care of my husband. These are things, when it comes to decision making, we need to consider. Then advanced care planning, talking about end of life care for children, it's not very common in many setups. And the biggest challenge is because children are not the decision makers. So we rely on their parents, but also sometimes we don't give them adequate information to help with these decisions. So what the parents need from us is, first of all, to understand the medical situation of their child, then to understand all the possible events and decision points that may arise. So what we look at is the prognosis and the uncertainties or the likely complications. This helps parents to prepare. So as I've said, advanced directives living wills, they are not common in the pediatric setup. So what we do is to have discussions. But again, the discussions with the parents, we need to give them full information so that they are able to decide. We've had a lot of parents who will tell you that they wish to take care of their children at home. Some will tell you they need you to communicate with maybe other family members. Children with congenital anomalies, children with sickle cell, sometimes children with cancer, societies believe they have been bewitched. So sometimes the parents want you to discuss with their other relatives. Do we give them a chance that if my child is sick and I would like you to have a discussion with my brothers, sisters, my parents, because the grandparents are involved in a lot of decisions concerning children, we should give them that opportunity so that we are able to organize the family conferences, we are able to have frank discussions, and where possible, we are able to support the parents. Because we've even had some parents, when their children get towards the end of life, they come back to hospital and they tell us at home, the in-laws have said, you cannot stay with this sick child, you go away. Some are even kicked away from their homes because of the sick child. So we should be ready to have these advanced care planning discussions with parents and children. And the emphasis is on understanding the wishes of the child, the wishes of the parents, then to help the family to be able to support the child who is dying and their parent. I'll now look at some basics of communication with the children and parents, and a little bit about conflicts. When conflicts arise in our decisions where we feel a child should be treated and their parents are declining the treatment. So first, when communicating with patients and families, generally these are some guides of how to do it. We need to use open-ended questions. So don't use questions of yes or no. Yes or no questions will not lead you to a discussion, but an open-ended question will help you to explore the issues of the patient and their family and support them well. Respond with empathy. Use a language that the child and the family can understand. And where you need to use an interpreter, please use an interpreter from the clinical team. Because when you use an interpreter from the family, the interpreter, you are not sure what they're interpreting. They will choose to understand the message and then say what they think the child or the family should hear. So try to use an interpreter from the clinical team. Make use of opportunities to address misconceptions about illness. Then we provide the information piecemeal. It is very stressful for someone to have a sick child. So don't bombard them with information at the same time, and then you also want decisions in that one sitting. Give them small pieces of information to digest, and then evaluate and reevaluate the priorities and decision options. So in the cases of emergencies, we want to start with what is urgent, because we need a decision most of the time to be able to act. So we start with what is urgent, and then we will break it down when the child is more stable to what is causing their illness or their complications. When it comes to cultural issues, when you meet a new family, please try and find out as much as possible how they make decisions. In some cultures, it's the men who decide. So um, right now in our ward, like in Kenyatta, the experiences, we have a mixture of caregivers. We have fathers and we have mothers. It's not like in the past, it was just mothers alone in the ward. And we also have uncles, aunties, and grandparents taking care of the children. But try and find out in that family who makes decisions, how is their culture, who needs to be consulted, because sometimes we need a decision and we're being told there's an uncle that we need to wait for. So find out. If there's anyone that needs to be talked to before a decision is made, can we organize to have that person as soon as possible in the family conference so that we can have a discussion with the parents of the child and the other significant people? Then the beliefs of treatment, we need to also explore what do these parents believe is causing their child's problem, and how do they think their child will be assisted by being in hospital, and what support do they need from us. So even before we start caring for a child, it's important to establish the culture, the spirituality, the beliefs, the values, so that we align our care to those things that matter to the child and their family. When it comes to communicating with the children, so there's two types of children here. There's a sibling and then there's the sick child. So for the sick child, we need to give accurate age and developmentally appropriate information. So we find a way to communicate with the child at their level. We encourage them to express how they're feeling, their fears, to support them and love them, and also give them the freedom to ask questions. Children are very perceptive and they look at your body language. When a child asks you a question and you frown or you seem irritated, they will not ask you another question because they already judge that they're disturbing you. So when you're going to communicate with a child, first ensure you have time. Don't be in a hurry. Sit down with the child, talk to them, make jokes with them, familiarize yourself with the child, create rapport, talk to them. Don't be interrupted with your phone or you are walking in and out of their room, because children need a lot of attention from adults. When it comes to the siblings, again, we'll communicate at an age appropriate and developmentally appropriate information is what we give them. And we need consent from the parents. And it's very important for siblings to be told what their sibling is going through. Because sometimes a child comes to hospital, stays there for a year, comes back home, has been amputated, their hair fell off, they've lost weight, their siblings cannot even recognize them, and no one has prepared these siblings for the support that they need to give the sick child, or even for their role as siblings. And sometimes because the parent has been away for long, the siblings feel neglected both emotionally and financially because more attention is given to the sick child. So it's important to encourage parents to talk to these siblings, and where they need our support, let them bring the siblings to hospital and we can be able to help them to communicate with them. Now, decision making in palliative care. So there are two perspectives I've talked about at length. So the overall aim is to improve the quality of life of the child and their family. So there's the perspective of the child and their family, and then there's the physician's perspective. So for us, we look at improving the survival of the child, curing where possible, and then giving treatment that will improve the outcomes of the child, relieving their symptoms. The parents are also looking at what is most important to them is to improve the quality of life of the child and to improve the survival of the child. And sometimes this does not match. Where it matches, we get quality of life. But sometimes we end up with conflict. So the first thing is to maintain continuity. So we need to support the children and their families and to make them feel supported. So where we need to transition them to other care settings or other health professionals, it's good to write a proper referral letter, give your contacts so that you are able to collaborate with the team where you are referring the patient. And also when they need to come back to you, if there's an emergency, let there be a channel of communication. Now, conflict can be prevented, and sometimes it still happens. And the common cause of conflict is where we do not agree on the management plan. I'll give you an example of a child we have in our care. So the child is 7 months and has come with gangrene of the upper limb, and the parents have declined the gangrene because they do not want to have a child with disability. The surgeons have said without without amputation, the child is likely to get sepsis and die. So the parents have refused to sign consent for surgery. So how can this conflict be averted? So first, there were some gaps in communication because the plastic surgeons and the orthopedic surgeons gave the parents a different level of amputation, and the parents themselves were not in talking terms. So the man had deserted the lady when she was pregnant, and now he resurfaced because the child was sick and we needed a decision about amputation. So first is to beware that disagreement is inevitable with difficult situations. And then disagreement is not synonymous with conflict. Disagreements actually happen, but the best way to handle is to have open, respectful communication. Can we sit round a table and discuss what is in the best interest of the child? And where we are not agreeing, instead of going on and on for hours, and then maybe sometimes the family members start insulting each other and the healthcare providers are caught in the middle, can we have further discussions at an agreed upon time? We postpone the meeting to a future date and we try to discuss small chunks of issues in every sitting. And then where there's emotional distress, name it, because it is very frustrating for a parent to be in the shoes of the parents that I'm describing. So try and acknowledge what is causing their distress and then try and support them through it. So again, we express interest in trying to resolve the situation. Let's have an open mind, to be willing to accept differences of opinion, allow family members to express their emotions, no matter how difficult it may be, and then respond empathetically. Now, agreement should focus on a decision rather than the emotions. So if we are having a disagreement on treatment, we are having a disagreement on whether to amputate a child or not, and medically we are saying failure to do this amputation is going to risk the life of the child, may even result in death. How do we get to focus on a decision that is best for the child? The parents have raised a concern that they do not want a child with disability. Are we able to link them with support groups of children with disability? Are we able to bring in the occupational therapists to explain to them how prostheses work? Are we even able to link them with other parents who have probably gone through this journey so that the decision making can be easier? So again, beliefs, values, uncertainty, they need to be addressed. We don't just say that, without an amputation, this child is going to die and we leave it there. A lot of ethical problems come because of the style of communication and the way we give information to parents. Because sometimes we make it look like the parents have no interest in the child. I remember one mother asking, the doctors and nurses are talking to me as if I don't care about my own child, yet I carried this baby for 9 months and I really care about the baby. And that's why I do not want to put my baby through this treatment. But again, sometimes our communication style looks like it's our way or the highway. And that again results in a lot of conflict with parents. Thank you so much for listening. I would like to stop there. Back to you, Dr. Korir. David, back to you.
Thanks. I was buying time for Dr. Coril to pick up. Hope she can hear us. That was quite a great presentation and intriguing thoughts and knowledge around how to support children and families of children with palliative care needs. Thank you so much, Dr. Esther Nafula for sharing and the insight. I see Coril is back.
Yeah, thank you, David. Sorry, I had difficulties unmuting myself, but thank you very much, Dr. Nafula, for those very great insights. Indeed, just as you have discussed, those are very pertinent issues that we face on the ground as palliative care clinicians and caregivers. And just maybe to give a summary before we go into the Q&A, I think some of the issues that you have highlighted is that as palliative care specialists, the overarching goal is to ensure quality of life of the child. You have mentioned the need for interdisciplinary teams rather than the multidisciplinary teams to ensure effective communication, and that as clinicians we speak one language, and therefore makes it easy even for the parents to make a decision. And then something very important that you have also talked about when it comes to ethical issues in pediatric palliative care is decision making. And you have highlighted the importance or the need to know that at the end of the day, these are children, and there's the legal perspective that binds us as clinicians, and therefore we have to abide by the law when it comes to decision making. Another thing is that we have to be culturally sensitive as we make decisions and ensure that we look at our culture, and so that even as we are discussing about decisions, we are culturally sensitive. Something also that is very important when it comes to decision making is that we need to support the parents to make decisions and empower them. So at the end of the day, it is not our way or the highway. We have to empower the guardians and to support whatever decisions that they make after we have communicated effectively. And then you have also given us some very good insights on basic communication skills and how we should communicate. And then as we communicate with children, we have to be very accurate, be developmentally sensitive, and give information appropriate for age. And it's also important to inform siblings. And then also when it comes to transferring patients elsewhere, we need to ensure continuity. And at the end of it, you've talked about conflict, and that conflict is part of care, and it's something that we will always face, and therefore we need to ensure that communication is respectful and it is open. We postpone whenever there are conflicts, and we don't need to make decisions immediately. So when there's conflict, we can postpone, let the emotions cool down, and then we can make decisions or help the parents or guardians make decisions. And then we have to acknowledge and support whatever decisions are made by the guardians, and also allow expressing of emotions. So thank you very much, Dr. Nafula. I think these are very important highlights that will help us even as we face this very important care in pediatric palliative care. So I just want to look at the Q&A section and see if we have any questions. I'm just checking, and it seems that there are no questions. The Cecilia, sorry. Cecilia is saying, thank you, Doc. Kindly share the slides. Elizabeth is saying, very educative. I have learned a lot. Thanks, Doc. And there's Leah also asking that you share the materials. So I don't seem to see any questions in the Q&A, but if there are any questions, maybe you can raise up your hand and then unmute yourself and go ahead and ask your question.
I can see Justin's hand is up. Justin, please unmute yourself and ask.
Justine, you can just go ahead and unmute yourself and ask your question, if you can hear us. Okay, so as we wait for Justine to unmute herself, I can see there's a question by Purity Metha. She's asking, hello, in cases where parents don't give consent completely, what happens?
So I'm interpreting that question to mean that you have partial consent. So probably you don't have written consent for a procedure or for treatment. So what happens depends on the institution. Where there is a hospital ethics committee, we encourage that you involve the hospital ethics committee because they'll be able to look at the issues around, okay, what is the decision that needs to be made? How urgent is it? Do we have time to give the parents time to think about it? And maybe also, do we have time to involve other family members in the discussion? And the family members, of course, would be nominated by the parents to the child. In the cases of emergency, then the hospital ethics committee needs to deliberate on how else can we get a decision to intervene for the child, because now in cases of emergency, lack of intervention means we could lose the life of the child, and that's not our primary goal when a child has come under our care. So in hospitals that do not have hospital ethics committees, then the escalation is through the nurse managers or the senior ACNs and the medical superintendent. And usually an ad hoc committee will be formed to make a decision about the care of the child. So there might be no dedicated hospital ethics committee, but it is good to escalate to the next person so that we also share. The decision making is best when it is shared, especially in matters that are not very straightforward. Thank you.
Thank you very much, Daktari. I think that question is well answered. Then we have another question from Phoebe Oguela. Phoebe is asking, how will it be for one who never did a post-test and pre-test?
I'm sorry, I don't understand the question. Did we have a pre-test?
I don't know. It seems, I don't know if what she's addressing, but maybe previous meetings. I'm also seeing that Doreen has raised up her hand. Doreen, please go ahead and unmute yourself and ask your question.
Okay, thank you. I'm Doreen. I would love to ask, can we classify sickle cell disease as life-threatening, or it's just a chronic illness? It's a question that I was unable to answer. Maybe if you could just clarify so that I am able to understand.
So sickle cell disease falls under life-limiting illnesses. So the natural progression of sickle cell disease is that there is increased destruction of red blood cells by the bone marrow, which eventually leads to destruction of the spleen and then liver failure and eventually death. So that's the natural progression of disease without intervention. So the only known cure for sickle cell disease is stem cell transplant, which is still out of reach in our resource limited setup. So sickle cell, mostly we would classify it as life-threatening because it's progressive, I mean life-limiting. Now, patients present with crisis. painful crisis, hemolytic crisis, and this crisis also lead them to a lot of hospitalization. So the best classification is it's a life-limiting illness, but again treatment, with treatment we are seeing less complications of sickle cell because there is now a lot of treatment that helps to prevent the complications. But without treatment, it would eventually lead to death. And again, the estimation is that many patients without treatment would not live to be adults. They would maybe just be teenagers, and then from the age of 18 to 21, that is when the liver failure and multiple organ failure sets in. What we are encouraging is that care should be given. In fact, screening should be done before the children are born. Screening of couples is important to know if they are predisposed to the sickle cell trait. So if they get a child who is a sickler, we are able to start giving them care early enough to prevent the complications. Thank you.
Thank you, Daktari. Doreen has said that she's understood. I am looking for any more questions. Florence is saying very educative session. Thanks, Dr. Nafula. Anybody else have a question? So it's 8:15. I think we can come to the end of the session, but I think before we close, let me ask David to say hi as we finish.
Sorry,
And
Doc,
maybe also
before you
address.
close, yeah,
Yeah.
there's a question in the chat from Christine.
Okay.
She's asking circumstances that can lead a parent to suing a facility due to decision making by a caregiver. Now, before you override a parent's decision, remember I mentioned where the parents are making a decision that is likely to lead to the death of a child because maybe we'll deny them life-saving interventions. Please prevent yourself from being sued by getting a court order before proceeding to give treatment against the wishes of the parent, and ensure that also, as I said, these decisions are not made by an individual person. So we would have a committee set up by the hospital to discuss the case of the child and then advise, because that is what will be presented to court. And then when a court order is obtained, usually in cases of emergency, it will be obtained very quickly. You are able to intervene. Now, in the event that a child dies, that is where you might get sued. We had a situation of a 15-year-old Jehovah's Witness who didn't need a transfusion actually in retrospect, but the child had sickle cell and had come in with multiple organ failure, and the HB was 6. And the ICU team felt the child needed a transfusion and transfused against the wishes of the parents without a court order, and the patient still died. So you see, when you look at the prognosis, that child was not doing well. They had already come with multiple organ failure. Their prognosis was bad. So before you go overriding the decision of the parents, ensure that your decision will actually save the life of the child, and then have a legal backing before you pursue that decision. Because at the end of the day, also, we do not want to create circumstances where parents are blaming themselves and where we are not supporting them, because that court legal process is very emotionally nasty, because you will not be in talking terms with those parents at all. And most of the times when they get discharged from the hospital, they will not even come back. So prevent yourself from getting sued. Get the legal channels, get the proper way to make the decisions if you feel the parents are making a wrong decision. But again, look at the overall picture of the disease, of the child, and the prognosis. Oh, the questions have started flowing.
Yeah. So I think Justine has asked, when a procedure is done following a legal order, who pays the bills?
The parents will still pay the bills because they came to hospital and they came to hospital seeking an intervention. So not making a decision does not absolve them from the responsibility, from the financial responsibility.
Okay, and then I think Michael is making a comment. He says, by centering the child's wishes and emotional needs as a child life specialist, I help ensure that even in the face of terminal illness, the child experiences love, comfort, and a sense of fulfillment. Programs such as Make-A-Wish and legacy building are just by a few ways of making end of life meaningful. So
Yeah, thank you, Michael. Please share with us the links on the intercounty group, because those were some of the tools I was referring to that can help us communicate with children. Thank you.
And then I think Justine is also asking, considering the hydration causes pulmonary edema, should it be done since it can hasten death?
Ethical issues. As I mentioned, ethical issues, there is no right or wrong answer. Because now we evaluate if a child has pulmonary edema, and then we would limit the amount of fluids we are giving in a 24-hour period. And sometimes there's actually room to stop if the fluid is going to cause more harm than good. But again, it's in consultation with the pediatric team and then with the parents. Thank you.
Thank you, Dr. So it seems we do not have any more questions on the chat, and I'm not seeing any hands raised. We don't want to close anybody out. So maybe as David makes his remarks, if you still have a question, there's still room. You can post your question in the chat or raise up your hand, and then we can address it just after David has spoken to us.
Great. Thank you very much, our speaker, Dr. Nafula, and our great moderator, Dr. Koril, and all the participants for joining. We went up to around 110, and we are grateful that at least at this time we've been able to join in and learn together. Quick announcement. Remember, October, the second week is the International Palliative Care Week. And this year we commemorate the week by celebrating 10 years milestone since the commemoration began. So we're giving an opportunity, or we have an opportunity to highlight our milestones as palliative care providers, either through short clips or through short write-ups or any other way, innovative way of communicating 10 years or milestones over time. Let's utilize that opportunity to showcase that palliative care works and what we've really been able to gain. Our next webinar will be done on the 23rd of October. And again, we will be communicating via the different forms. We welcome you to join in. That's it. I think that brings us to the close of the session. We must appreciate you for the good work that you do. Asanteni, thank you very much. May you have a good night or good morning for those who are joining from various other different time zones. God bless you all.
Thank you, David. Maybe just before you go, there's one more question on the chat. Faith Gatiga is asking, what about if the parents opt out, contemporary treatment, and go for herbal treatment? What would we do to protect the child?
We still involve the hospital management, because again, herbal treatment could be potentially harmful to the child, and we involve other family members in the decision. So the protocol is the same where we feel the parents are not making correct decisions for the children. Thank you. We'll share the slides. Thank you.
Yeah. So thank you very much, Daktari. I think this was very insightful. And thank you everyone for making time. Hope to see you in the next webinar. Have a good evening. You're free to leave.
Good evening to